Welcome again to our weekly EKGs. I'm John Felt, and I'm joined again by Dr. Sriram with our cardiology group. So the case that we have for this week, this was an 11-year-old that actually presented to the ED just a few weeks ago. She presented with a complaint coming from her pediatrician's office. She had presented there with a complaint of palpitations, heart racing, that had been going on intermittently for the last couple of months but seemed to be happening more frequently. The pediatrician did a bedside EKG and was concerned, and so sent her in for evaluation. When she arrived, she looked well. She was interactive. She had nothing really on exam. Her heart rate was normal. And so we also proceeded to do a repeat EKG because we didn't have the pediatricians, and this is what we got.
Thank you for showing this ECG. So right off the bat, when you're assessing a patient with palpitations, obviously you have to kind of assess to make sure that they're in sinus rhythm versus SVT. That's obviously goes without saying. But here you look for sinus P waves in a patient who's got a normal heart rate. You assume that they're in sinus rhythm, and you start looking by looking at the P waves. And if you look at the P waves here, again, you would notice that they are positive in 2, 3, and AVF, and they are also positive in 1 and AVL, suggesting that they're coming from the right side and from a superior location on the right side, suggesting that they're coming from the high right atrial region, which is the region where you expect the sinus node to be. And again, the P wave morphology looks normal and positive in the precordial leads. Sometimes you can have a little bit of a terminal negativity in lead V1 with sinus P waves as the P waves as the atrial depolarization is moving away from lead 1 into the left atrium.
And we see that here.
You actually, here you don't obviously get a nice sense of PR interval to make that comment.
Okay.
But usually when you have a normal PR interval, you can appreciate that in many patients, like a terminal negativity of the P waves in lead V1 that is compatible with sinus rhythm. And right off the bat, then you look for QRS, and then you look at the morphology of the QRS, and then the QT and the T waves. So here, if you look at the morphology of the QRS, it doesn't look completely normal.
Right. And
then you sort of see that the PR interval is somewhat shorter eyeball in it, and you can actually measure it, and it'll be shorter because you conduct from the sinus node throughout the atrium, and then you go through the AV node and then into the ventricle through the His-Purkinje system. So you expect sort of a nice separation between the P wave and the QRS, because the AV node does not produce any waveform on the ECG. It's pretty silent, and it kind of takes a while to conduct to the ventricle. Right. So you usually see an isoelectric. If you don't have any artifacts on the ECG, you expect to see an isoelectric interval between the P wave and the QRS, which is most of the delay that's happening in the AV node.
Right.
Here you don't see that. It seems like the ventricle wants to start activating right after the QRS, and then you have to wonder, well, is there any connection between the atrium and the ventricle that bypasses the AV node? And that pattern is called pre-excitation, which means that you're pre-exciting the ventricle. You're exciting the ventricle before you can excite the ventricle through the normal AV node. So pre-excitation most commonly and most often is due to an accessory pathway that conducts from the atrium to the ventricular myocardium. So you have the atrial myocardium on one side and ventricular myocardium on the other side, and these pathways live close to the annulus, and most of the times they are short, and they attach the atrium to the ventricle and the annulus.
Okay.
And that's why, and the pathways, unlike the AV node, are usually not decrementally conducting.
Okay.
And they conduct rapidly. As soon as the atrial activation hits the pathway, it conducts rapidly to the ventricle. And that's why here you see that the QRS onset, as evidenced by a slurred delta wave, is seen right after the P wave. And you can see it in multiple leads. You can see it in lead V1 here, this portion, and you can see it in lead 2 as well, and in lead 3. So you can see it in multiple leads, and that just means that there is a activation of the ventricle soon after the P wave starts or just before it terminates, and you don't have to wait till you conduct through the AV node. You can still conduct through the AV node, and in this case you do, which results in a fusion beat between the pathway and the AV node. So you're conducting through the pathway into the ventricle, and you're activating the ventricle right off the bat, but you're also conducting through the AV node and the His-Purkinje system, which takes a little longer.
Right.
And that's why you see the fusion between the pathway conduction and the AV node conduction. Go ahead.
So why is it that these patients then will have the symptoms of palpitations and heart racing? Do they actually slip into an arrhythmia?
Right. To answer that question, the answer is yes.
Okay.
But I want to focus a little bit on the delta waves so that
Sure.
we can
Understand why.
understand why that happens. Remember, when you have this His-Purkinje system, it's a very rapidly conducting cable system, and it kind of arborizes all over the endocardium, so allows for a rapid conduction to different areas of the myocardium, and rapid conduction is really sharp, and you see that narrow QRS.
Right.
Whereas when you conduct through the pathway to the ventricle, you don't have the benefit of conducting through the conduction system, so you have to conduct cell to cell through the myocardium,
So it's delayed.
and therefore you see that slurred pattern. The slurred pattern is just suggesting that there is delayed or slower conduction. You conduct through the pathway rapidly to the ventricle, but once you hit the ventricular myocardium, you're not conducting through the conduction system as you'd normally do.
Got it.
And because of that, there's slightly slower conduction between the ventricular muscle cells, as opposed to conducting all over the myocardium through the rapidly conducting His-Purkinje system.
Okay.
And therefore, you see that slurred pattern, which is suggesting a slower conduction, muscle-to-muscle conduction between the ventricular myocardium. But of course, the QRS becomes sharper because then eventually the His-Purkinje system also starts conducting, and it starts to normalize the QRS.
Okay.
So that's why you see that pre-excitation pattern. And the more closer you are to the sinus node, the pathway to the sinus node, the more obviously you're going to see more pre-excitation. Sometimes the pathways can be left-sided, and it takes a longer time to get to the pathway, and you're already conducting through the AV node. So in those patients, you may not see a lot of pre-excitation. But in this patient who has a right-sided pathway, it's much closer to the AV node. It gets to the pathway right away and starts pre-exciting the ventricle.
Okay.
So that's why you see that
Right.
pre-excitation pattern. I want to kind of focus in on a couple of other things that
Sure.
you would want to notice. When you have abnormal depolarization, because now you're not depolarizing the ventricle through the normal His-Purkinje system, which you do eventually, but you're also using the accessory pathway, because you have abnormal depolarization, you might have abnormal repolarization, and a result of that, you might see some T-wave changes.
Got it.
Doesn't mean that the patient has myocarditis. And you also see these pseudo-infarction patterns in lead 3, which is another sign that there might be a pathway. So if you start seeing these pseudo-infarction pattern, how often have you seen an 11-year-old had a myocardial infarction? I've never seen one.
Certainly not a previously healthy one.
So, and then, when you see these funny Q waves, always look for pre-excitation.
Okay.
Sometimes this pattern is called pseudo-pre-excitation. It's not really, pseudo-infarction pattern. There's no really infarction going on. There's no scar or any myocardial infarction going on. It's just an abnormal pattern of activation of the myocardium.
Okay.
And that tells you that there might be a pathway. This diagram shows that the sinus beat that's coming from the sinus node is traveling through the atrium, and basically electricity flows wherever it can. The annulus is basically a fibrous ring. So you can't conduct across the annulus because there is fibrous ring across the atrial and the ventricular myocardium. So the only way you can normally conduct across the annulus from the atrium to the ventricle is this AV node, which traverses that fibrous ring.
Yep.
And specialized conduction system. So in that case, if you only conduct through that His-Purkinje system and AV node, you produce this delay in the AV node, which gives you that PR interval.
Right.
And that narrow QRS suggesting that you're conducting
All at the same time.
everything through the same
Rapidly.
rapidly to both ventricles, and therefore you don't take a lot of time to activate the ventricles, and it's fast conduction, so your QRS is narrow.
Okay.
Now when you take out the AV node, either by giving adenosine or ablate the AV node, which you don't normally do, all you are left with is a pathway, then you would see a very fully pre-excited QRS.
Okay.
Now you don't get a chance to see that because the AV node starts conducting. After a while, it does allow the impulses to travel into the myocardium.
Got it.
So somewhere around this point, there is conduction through the His-Purkinje system, and the QRS starts to narrow. But till that happens, you're able to see that nice delta wave. So then it's very obvious that if you have a right-sided pathway here, then you get to that really quick and you get to the AV node maybe around the same time, but you conduct across the pathway really quick and start activating the myocardium. And then the AV node also starts conducting to the His-Purkinje system, and then you normalize the QRS.
Yeah, so I guess, the question becomes, what rhythm do they go into usually? Why is it that they get the palpitations and the heart racing? And then, from an emergency medicine standpoint, how stable are these patients for us to be able to send home?
Right. Obviously, if they are in a palpitation at the time of presentation and they have SVT,
yeah,
which in this case would be a narrow QRS complex SVT, most often is the case. What happens is you might, during SVT, and they can have two flavors of SVT. One is called the orthodromic SVT, where you go antegrade from the atrium to the ventricle using the AV node and the conduction system, and your QRS is expected to be narrow, but back to the pathway, and then return to the atrium using the pathway.
Got it.
So that's going to be a narrow QRS SVT, because you're using the AV node His-Purkinje system to conduct to the ventricle. Now, everything has always got an exception. Sometimes you can have one bundle that is blocked, so that can produce an orthodromic ORT, but in this case,
got it.
But it's still going down at least one cable of the conduction system. Your right bundle may be blocked, but you're still going down the left bundle, or the vice versa. You're still going down the conduction system despite it being wide in the case of a bundle branch block. But most often, you use both bundles to activate the ventricle simultaneously, so your QRS should look pretty similar, or almost similar to your sinus rhythm. It should be narrow. Rarely, or much less commonly, the opposite scenario happens, where you go from the atrium to the ventricle using the pathway, and then activate the ventricle exclusively through the pathway.
Okay.
And it's going to be a wider QRS. It's going to look bizarre and wide, but it's going to be monomorphic because there's only one way of activating the ventricle. You might even think this patient has VT.
Okay.
Because what is a VT if not activation of the ventricle through the myocardium?
Right.
And it's kind of like functionally, you can say that I'm activating the ventricle exclusively through the myocardium, not through the His-Purkinje system, so they're going to have a wider QRS.
Yeah.
But the key here is that the wider QRS is an antidromic reentrant tachycardia, antidromic AV reentrant tachycardia, using the accessory pathway to conduct antegrade from the atrium to the ventricle, producing a wider QRS. And then you come back to the atrium using the His-Purkinje system and the AV node.
Yeah.
So in that case, it's going to be wide.
Wide, right.
And remember, whether you have orthodromic or antidromic AVRT, what forms the circuit? In this case, the circuit is formed by the atrium, because you need the atrium to,
right.
And then you need the His-Purkinje system and the AV node. You need the ventricle, and you need the pathway.
Yeah.
So everything is an obligatory part of the circuit.
Right.
So atrium, your AV node His-Purkinje system, your ventricular myocardium, or at least the ventricular myocardium that is in continuation with the pathway, and the pathway are all parts of the circuit.
Right.
So if you block
one
either in the
those,
pathway or in the AV node, you would terminate the tachycardia.
Yeah.
So this orthodromic or antidromic AVRT is an AV node dependent tachycardia because it uses AV node as part of the circuit.
Right. So therefore.
So if you give adenosine to a patient like this, you will take away the AV node, and then you will terminate the tachycardia.
Got it.
Correct?
So that's the goal.
That's the goal.
Yeah.
You don't have to block the pathway when you're in AVRT. You just need to block the AV node, and that's why you give beta blockers to these patients,
right.
so that they're less likely to go into SVT.
Okay.
You try to control one limb of the pathway.
Right.
Obviously, if that doesn't work, or if they're in hemodynamically unstable state, for the ER physician, obviously you assess them whether they are in hemodynamically stable or unstable state. Try vagal maneuvers if they're stable. And if you have a chance to put an IV line, you do that, and just the act of putting an IV line might terminate the tachycardia.
Right.
And if that doesn't work, you do adenosine to block the AV node. You can give 50 to 100 micrograms per kilo,
right,
depending on the weight. Obviously, if the patient is unstable, repeated doses of adenosine have not worked, then you consider
synchronized cardioversion.
Synchronized cardioversion, where you synchronize with the QRS.
Yeah. So to summarize in some of the learning points, so we have a patient here that presents with a slurred upstroke in their QRS, which would be consistent with an alternative conduction pathway, colloquially known as Wolff-Parkinson-White in this case.
Or pre-excitation.
Or pre-excitation syndrome. In our case, this patient was stable, so it was able to be managed with oral beta blockers, and we'll plan to follow up with an electrophysiologist at a future time, or a cardiologist, for further evaluation. But obviously the ER physician needs to be able to evaluate whether or not the patient is in SVT and whether or not they're stable, and then proceed down the standard PALS algorithms to be able to manage them. So thank you again.